Hi, hello everyone. Welcome to Dr. Ravichandra Official. In this video, we will discuss a topic on blood bank or transfusion medicine. After a blood transfusion, there will be most of the times transfusion reactions due to various reasons. The transfusion reactions can be acute and delayed. Acute is within 24 hours and delayed is more than 24 hours if any transfusion reaction occurs. Acute transfusion reactions can be immunologic and non-immunologic. Under the immunologic, they can be hemolytic transfusion reactions or febrile non-hemolytic transfusion reactions, allergic reactions, transfusion-related acute lung injury. Febrile non-hemolytic transfusion reactions are the most common transfusion reactions that are going to be seen very regularly. So they are the most common transfusion reactions. Coming to the non-immunologic acute transfusion reactions, they are bacterial contamination, transfusion associated circulatory overload or TACO or circulatory overload, and physical or chemical hemolysis. Coming to the delayed transfusion reactions that will occur after the 24 hours, they can be immunologic and non-immunologic. Under the immunologic delayed transfusion reactions, they can be hemolytic transfusion reactions, transfusion associated graft versus host disease, and post-transfusion purpura. Coming under the non-immunologic delayed transfusion reactions, it is transfusion-induced hemocytosis and others. We will discuss one by one the most important ones: transfusion-related acute lung injury, transfusion-associated circulatory overload, and transfusion-associated graft versus host disease and post-transfusion purpura in the next few minutes. Acute transfusion reactions are the transfusion reactions that occur within 24 hours after the blood transfusion. So the component that is causing acute hemolytic transfusion reactions are the most severe ones. The recipient will have the anti-ABO immunoglobulin M in plasma that will react with the donor red blood cells, and these IgM binds with RBCs and activate the complement, thereby causing the RBC lysis and some phagocytosis to kill these RBCs. As a result, there will be symptoms, fever, chills, and there will be hypotension, hemolysis, and renal damage. Prevention is by typing, screening, and matching the blood before transfusion. Coming to the febrile non-hemolytic transfusion reactions, these are because of the components blood product containing anti-WBC antibodies and cytokines. Antibodies bind recipient white blood cells and stimulate the cytokine release. Combined cytokines will cause the symptoms: fever, chills, high respiratory rate, anxiety, high or low BP. In acute hemolytic transfusion reactions, there will be hypotension, but in febrile non-hemolytic transfusion reactions, there can be high BP or low BP. And these febrile non-hemolytic transfusion reactions can be prevented by using leukocyte reduction RBC for transfusion. Coming to the allergic transfusion reactions, these are because of the blood products containing the allergens for that individual. Allergens from the blood cross-link the immunoglobulins E, Ig, E is present on the recipient mast cells, which will cause the degranulation and thereby causing the symptoms. There will be hives, itching, and occasionally anaphylaxis. So these allergic transfusion reactions can be prevented by using the washed cellular components for transfusion. Coming to the transfusion related acute lung injury, which is very important. These are because of the blood products containing anti-HLA antibodies and anti-neutrophilic antibodies. Antibodies from the plasma react with the recipient lung tissue, thereby causing neutrophilic infiltration and inflammation and pulmonary edema. And this will cause acute respiratory distress syndrome like symptoms and pulmonary edema, non-cardiogenic. Okay, and this can be prevented by not accepting the plasmas. Coming to the TACO, that is transfusion associated circulatory overload. This is because of the increased blood product volumes. Massive transfusion, that is 4 to 5 liters within 24 hours, or more than 2 liters within 3 to 4 hours blood transfusion will cause in massive blood transfusion reactions, that is TACO, transfusion associated circulatory overload, and there will be excessive volume causing high RAPs and pulmonary edema. So the symptoms will be acute pulmonary edema. So prevention is by transfusing slowly the required amounts and required products as per the need. As I said earlier, probably they are presenting as non-cardiogenic pulmonary edemas, and there is highest risk with plasma-containing products donated from every ever pregnant females due to HLA allo antibodies. And new guidelines will restrict ever pregnant donors from donating plasma-containing products unless they have been tested negative for anti-HLA antibodies. This was the recent update. And treatment will be supportive therapy, usually does not respond to the diuretics. It is important to notify the blood bank so that they can quarantine any other blood products from the same donor and potentially restrict the donor from future donations. And the recent update related to TACO will be, it is the most common cause of transfusion related mortality and pulmonary edema due to excessive volume or rapid transfusion, and the treatment or supportive therapy are using diuretics and slowing down the rate of transfusion. Coming to the transfusion associated graft versus host disease, this is extremely rare late infection, which is a delayed transfusion reaction. So the donor leukocytes will attack the recipient cells. They can be prevented by irradiation of the units for at-risk patients like neonates, immunodeficiency persons, recipients of bone marrow transplants, transfusions from a blood-related donors. The symptoms in the transfusion-associated graft versus host disease will be, they will be presenting with fever, abdominal pain, liver dysfunction, pancytopenia, and diarrhea. Advice will be there is a need for hematology consultation, and use of steroids and immunosuppressive drugs will help the reaction. Transfusion associated graft versus host disease will have a high mortality rate despite treatment, so these persons have to be given utmost care. Coming to the post-transfusion purpura, it is a rare delayed transfusion reaction, and recipients' alloantibodies will attack the donor platelet antigens, and they will be presenting with purpura, epistaxis, and thrombocytopenia. So hematology investigations has to be done, and IV immunoglobulins is the treatment of choice. Thank you for patient listening. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos on pathology.